Welcome to the Veterinary Podcast, brought to you by Sedical, the world leader in veterinary-specific X-ray technology. Visit veterinary.com to find a solution for you.
We are very excited to sit down and talk today with Dr. Badertscher, a boarded veterinary radiologist, about diagnosing two common conditions, respiratory distress and vomiting. We all have heard that to a hammer, everything is a nail, but to Dr. Badertscher, he has some insights that will really benefit everyone. Please take a look at our website for Dr. Badertscher's extensive background information. With all that being said, let's jump into that conversation with our host, Emery Shelley, and Dr. Badertscher.
Well, thank you, Dr. Badertscher, for spending time with us today. I've been impressed with you for years, the years that I've known you, for your knowledge in radiology, your depth of knowledge. And just the other day when we were talking, I found out that you had been a general practitioner, and now occasionally you do some work as a general practitioner to fill in and help people out, and how you've approached some of those cases much different than a normal general practitioner would. And so what I wanted to do is just kind of get some of your insight on how, if you were a general practitioner and let's say a vomiting case presented itself, how you would approach it maybe a little bit differently and maybe with a little bit more depth given your radiology background. So that's kind of where I'd like to take off here. And tell me some of your experiences where you found your knowledge helpful, and it's really helped the patient and the client and everybody involved.
Well, when I was in academia for a number of years, I never saw the clients with the patient at the time. And then when I had two specialty practices that I was a partner in, the internist or the clinician would see them and then bring the animal to radiology for further workup and then interpretation. So during the last 6 months or so, I've been doing some locum work and relief work for some of the colleagues in the area. And I've found that my approach is different now than when I was in general practice 40 years ago. And so I think that we might be able to shed some light or maybe even a different type of thought process as we go through this. And you mentioned a vomiting dog. And I think that probably in radiography nowadays, that radiography of the abdomen is the number one place that people go, unless it may be for some kind of lameness, and we won't go into that today. But when a patient is presented, the first thing that all practitioners do is meet the client and the patient in the exam room, and then they start to get a history, and their technician may have already got some of that history. But in talking with them, they usually find out within 3 to 5 minutes that the patient has been vomiting for maybe only 24 hours or maybe for 2 weeks. And so that duration, I think, is helpful in understanding what we might expect to find on a radiograph. The second thing is they're always going to be questioned if they've been eating anything, chewing on anything, gotten into anything that could be either toxic or chewed it up and swallowed that. Some kind of foreign body would be what they would be expecting to find. And so radiography is often indicated. And I think in most cases, at least what I used to tell my students, that if you have an animal that is vomiting for over a 24-hour period of time, the use of radiography is very helpful in making a plan and initiating a treatment regime for that patient. So radiographs are one of the first things we may go to for a vomiting patient. A lot of times they will also get a CBC and a serum chemistry to rule out pancreatic disease, to rule out dehydration, to look for liver enzyme elevation, and even chronic renal disease, to look at the different main organs, critical organs within the body. But the radiographs, when they're made, should be made at least 2 views. I know some people like to sneak by with just a lateral view, and I would say that that's the first view I look at is the lateral view. But two views really helps to locate, as everybody's been taught in vet school, that creates that three-dimensional image in your own mind. So you need the two views at 90 degrees to one another so you can recreate a three-dimensional image.
Is there any more value to doing a right side lateral and a left side lateral? Or?
That's a great question, because in a lot of times, especially with the stomach and with a vomiting dog, that by doing a left lateral recumbency, in addition to the most people do the right lateral, but you move the gas and you move the fluid around in the stomach by gravity. And quite often on the left lateral recumbent view, the air will go up into the pyloric antrum and will start to go out the duodenum on the right side. So that gives you a better view or idea of the pathway that the food would be going through. And it moves the fluid to the left side into the fundus when they're in left lateral recumbent view. So quite often I will instruct the technician to go back and do a left lateral or to do a right and left lateral at the initial examination. But I think that most practitioners, because of the way X-ray rooms are set up, will do a right lateral recumbent and a VD view. A DV view can help too, but I find it the least beneficial of the four recumbent positions. And so right lateral and VD are the two most common used, and then a third addition would be the left lateral recumbent view.
Is there any value to horizontal beaming, standing the animal up?
There is. Unfortunately, now a lot of the X-ray tubes do not go down to the table level. You've got a 80-pound dog and trying to get them in position, but you can lay them in lateral recumbency and shoot a VD view with horizontal beam. The other thing is that with DER systems, digital radiography systems, the plate is usually underneath the table, and because of the connection with the computer and the X-ray machine, it's very hard to disconnect and move that out. Now, there are wireless systems that are out now. They're quite expensive. They're used a lot in large animal, and I've used them in small animal, but most of the time that takes an extreme amount of time, and I think the value of horizontal beam is pretty low, and probably most people would not use that.
So they can be real comfortable just doing a right side and a left side lateral recumbency. And
comfortable, I guess, would be not the word I would use. It would probably be the most complete. And so a complete study would include both lateral recumbents and a VD view.
Okay. What other things would you be looking for? Again, if you did not know that there was a foreign body there, are there things that are minute changes that you look for in the bowels to, if something's not radiolucent?
Well, actually, on the VD view with pancreatitis, you're really looking for loss of visualization of serosal margins. The outside of the stomach wall, the transverse, ascending and transverse colon, and some of the intestines between the stomach and the bowel are displaced, and there is a soft tissue density on the VD view underneath the right 12th and 13th rib. And so when you see that blurred appearance, that should tip you off that we could be dealing with something that's outside of the GI tract but still involved that could be causing the vomiting. Also, many times the descending duodenum will show up very well, quite often with gas, and it can be displaced or it can show signs of adynamic ileus, a uniform distension of the descending duodenum with gas.
Now, you told me just recently you had a couple unique cases come in where you've had to go through.
Well, I think that a thorough evaluation of the radiograph is the most important, because too often practitioners have already made the diagnosis in the exam room. They are sending the technicians quite often, sometimes yourself like me, to go in and help take that radiograph. And then you're looking to see, is there a radiodense foreign body or a mineral foreign body or whatever in the stomach or in the small intestine. But there are some radiolucent foreign bodies. Corn cobs are very hard to diagnose sometimes. Other items such as sock and cloth material are hard to detect sometimes. So, yeah, I think that there are instances where even the radiograph does not show it, but the other signs that we were talking about a minute ago is what is the gas pattern in the stomach? Is it distended? Is it mostly gas? Is it mostly fluid? Is the duodenum visualized? And look at the jejunum and even back towards the cecum where the ileocolic valve is. And that's usually to the right of the spine on the VD view at about the level of L3. So you can look over in that area. Quite often it's hard to detect except if you have a severe distension of the cecum. But if you're looking for the pattern in the small intestine, and if the diameter of the small intestine is greater than 3 to 4 times the width of a rib, it usually means that there is some kind of obstruction, partial or complete, of the small intestine, and that may be where a foreign material might be hung up. And ileocolic valve is one of the most common places.
Well, if the animal's been vomiting for 24, 48 hours, and you do radiograph, and you do see maybe something there, is there a value to retaining the animal for maybe another hour or 2 hours and doing a follow-up to verify if it's not quite obvious right away?
Well, I think time is on our side too there, because vomiting is usually not a critical condition that is life-threatening right at that time. Pancreatitis is chronically life-threatening. An intestinal obstruction that is not allowing anything to pass becomes a necrotic bowel, but that's usually 24 to 72 hours later. And so I think that immediate re-radiography, even that day, is probably of less value and economically may not be the most prudent thing. However, I did have a case just last week where the owners presented a dog, I think it was about 24 hours after it had been at the daycare center. And they said, we don't know why the dog is vomiting. We had it at the daycare center, and could you take a radiograph? And we did. And we found that there was circular rubber material within the stomach, difference in shape. But they said, oh, yes, they play with the dog with a tennis ball at the daycare center. And the dog had ingested 3 or 4 pieces of the rubberized tennis ball. There was also an area back near the ileocolic valve that was similar in density but was not obvious because of some of the fecal material back there. And so we could not get the dog into surgery that day. I'm not sure it was indicated. The dog was alive and wagging its tail and happy as could be, except when we fed it, then it threw it right back up again. So we left the dog hospitalized overnight, and the next day we had it scheduled for surgery. But one of the things that I've learned in the past is that what was present the day before may not be in the same place the day after. And so prior to going into surgery, 15 minutes in fact, I suggested that we take follow-up radiographs just for comparison so they would know whether they needed to do a gastrotomy or an enterotomy or do both. Lo and behold, when we took the radiographs, there was nothing in the stomach, and the previously visualized ileus within the small intestine was atypically changed. There was really no evidence of obstruction then. The colon was completely empty of fecal material, and we said it probably is not necessary to do surgery. And then the kennel attendant came in and said, oh, I found these in the cage where the diarrhea had been. Could this be the tennis balls? And the dog had passed all 4 pieces of the tennis ball.
That's wonderful.
And so we didn't make any money on that case, but we were at least able to prevent the dog from going through unnecessary surgery and trying to explore the whole abdomen, trying to figure out where the foreign material was, and it was already in the cage.
Now, would you say if there's foreign material in there and the owner's been a little lax in bringing the animal in and it's been 48 to 72 hours, that creates more of a sense of urgency to maybe go after it surgically?
I think it's probably more the number of times that the dog's vomited within a period of time. And if a dog vomits once every 2 or 3 days, and that's probably been going on for weeks, if not months, or if it's vomiting once a day, or if it's vomiting 4 or 5 or 6 times a day, that would be the urgency, because the more a dog vomits, especially if it's given water or given some food, the more likelihood that it's an obstructive pattern that's going on in there, or that we have a medical condition such as pancreatitis or some kind of peritonitis that would be causing an irritation to the stomach. Now, you mentioned about whether there is a difference for the history. And I think the other thing that we need to think about sometimes before going to surgery is that if we can't see the actual underlying etiology for that obstruction, yet we think that there may be something in the intestine, then an upper GI study is valuable. And a lot of times those aren't done quite appropriately either. You need to use a suspension of barium sulfate, not the old powdered barium products, but most drug companies have these small containers that you can mix up dry powder with fluid and water and then administer it. One of the other things with an upper GI study is that people don't usually give enough contrast media. And my recommendation is that for every 10 pounds of dog, they should get 60 cc's of the solution. Now, that seems a lot, and especially if you got a 60-pound dog, you're given 360 cc's. I hope I did the math right. And that takes some time. And so what I usually do is do a stomach tube and pass the stomach tube down into the stomach and then administer the barium with a 60 cc syringe that has the catheter tip on it so that it can be placed snugly in the esophagus, the stomach tube that's down there. And then take radiographs immediately as soon as you've passed that. And that should be done in all 4 planes. You were talking about planes before, so both right and left lateral recumbency, the VD, and the DV view are important right immediately so that we can see where that barium is in the stomach. By that time, usually some of it's already out in the duodenum, even within 10 minutes. So we want to get it to be able to see the coating in the stomach to see if there's any foreign material that could be causing a filling defect there. And then I usually recommend the right lateral most of the time and the VD view at about 15 minutes, at 30 minutes, at an hour, 90 minutes, 2 hours, and then hourly thereafter until the contrast media has reached the colon. Now, what a lot of times I see radiographs sent to me for consultation is that they've gone for 4 or 6 or 8 hours. Once it's in the colon, we're not looking for the colon because we're dealing with either diarrhea or we're dealing with vomiting. And so once it's passed out of the stomach and it's into the ascending colon, the study's pretty much complete. So usually you're going to take anywhere from 10 to maybe 14, 16 radiographs in that 3 to 4 hour period of time, or even sometimes in a cat it's going to be faster, that you'll be done with an upper GI study in 2 hours because the transit time through the small intestine in a cat is a lot faster than in a dog. But you'll also see obstructive patterns that way, and you can see filling defects because if there is something left in the stomach or in the duodenum, the proximal part of the small intestine, it will retain the barium in the cloth material or whatever the radiolucent material is. And so it's once passed, you'll still see that retention within the material that is in the GI tract.
That's interesting. Even if it's something with a little plastic, there may be some retention around it?
Well, the plastic probably not, but anything that's porous that the barium can adhere to, the surface of a tennis ball. But if it's a fairly large size object, then there will be a radiolucent center, especially after some of the barium has passed from the stomach. So something like a golf ball or something like a handball or even a rubber toy or any other kind of material like that. Leather quite often will show up later on. So those kinds of things. The smooth things like plastic, you almost have to catch it at the right angle to see the filling defect, but you can, and you may get a hint of it later on as well after the barium has passed.
Anything else that comes to your mind as you've been?
Yeah, well, one last thing with upper GI studies, and it was always for any of us that graduated probably before 1975 or 80, and I was in my residency in that period of time, they always told people never to go into surgery right after doing a barium study. And that was proven to be definitely wrong way back then. It isn't the barium that's causing any kind of complication with peritonitis. It's the intestinal contents, the juices, the gastric juices, the bacteria, and everything else. So if you're going to do an emergency surgery, it's going to be the same whether it's got barium in it or not. Now, I know with endoscopy, they don't want it to plug up the scope, but with radiography and having barium in there, it's a little bit more messy, but it's not going to be a contraindication to do surgery the same day that you've done an upper GI study.
Well, thank you. That's been quite a nice review of how to approach a vomiting animal. I'm wondering, are there other conditions where you find radiography can be an added value rather than just taking one quick image, maybe like in a respiratory distress situation?
Yeah, again, going back to the presentation of the case, I don't know that we see too many emergency respiratory cases in general practice. I think that more often we see a dog that is coming in with coughing, with dyspnea and heaves sometimes, or with just stress and tachypnea. They're breathing very hard. Now, I've got to rule out some of those brachycephalic dogs like pugs and bulldogs and those because they have other conditions that they're born with, and the breeders don't seem to want to breed those out. They want to perpetuate it, and veterinarians are very happy to be able to keep the clients coming in. But when an animal is presented and auscultation of the chest is done, often the heart sounds are either going to be muffled or there are no abnormal heart sounds. But when you listen to the lung, you're going to quite often hear rales or some kind of bronchial pattern or changes that are going to go on that make it more difficult to auscultate a normal thorax. So then you start to think about how is best to make a diagnosis. And it was stated a number of years ago that thoracic radiography is probably indicated in 80 to 90% of the cases we see with any kind of respiratory problem, because you're going to see the extent of disease, and you're going to be able to localize that disease and probably even get a jump on how to treat that disease once you take the radiographs. Now, where do you radiograph? Again, it's like the abdomen, but I would caution that especially with these new DR systems, the image resolution in the thorax is just phenomenal. You can see things that are so minute in the lung with the 14 or 16-bit detectors that we overdiagnose now a normal dog because we see so much more.
I think my experience has been when people go from film to digital, they immediately overdiagnose just because, again, they haven't been used to that level of detail, and they assume they're bronchograms, that there's a problem there.
Right. And it's just that we have such superior resolution now, and that we can stop the respiratory motion that used to be a real big problem with films because of the speed at which these images are captured, that it is we're seeing a lot more. But still, I think localizing is very important. But again, I got off track there, but again, what we want to think about is the technique. And the technique for a thorax is going to be different than a technique for an abdomen. And a lot of the systems, like the one that Sedical has and Vetray has, or Vetel or even Sound have, that we can set up a different algorithm for the thorax than we do for the abdomen. And that's where we're going to improve the resolution very substantially, is through the different algorithms. Now, some of the older DR systems have very poor algorithms, and the images, I think, are less than diagnostic in some of those that are more than 10 years old. Those DR systems, I think, are pretty much antiquated and don't have the new software packages that the newer systems have. The second thing is that we're going to take right lateral and VD views, just like we did with the abdomen. But the left lateral recumbent view is very helpful quite often, not just to detect metastatic disease, which is what AHA highly recommends 3 views of the thorax, but also to see the up lung, which is going to be more air-filled, than the recumbent lung, which is going to be collapsed a little bit more, and the heart would be deviated with gravity towards the table. So quite often, especially in cases where I suspect pneumonia or a lobar kind of lung disease, that both the right and left lateral recumbent views are helpful in seeing where the disease is and the extent of disease. Some of the patients that are presented to us have a cough, and it depends upon the breed a lot of times, but including the cervical area to look at the pharynx, both the nasal pharynx and the oral pharynx, as well as the trachea and esophagus, gives us some idea sometimes of where the cough is in the upper airway and not down in the lungs or the lower airway. If you have a coughing patient and you're not seeing anything specific on the thoracic views, extending up into the cervical region, taking it more at a soft tissue technique, much like the abdomen, will help you to evaluate that. And certainly in bulldogs and brachycephalic dogs, tracheal collapse, especially overweight chihuahuas and dachshunds, tracheal collapse is a real problem. Now, it's a dynamic disease, and so you may not, on a single exposure of the cervical area, pick up that. But at least it would be good that you've tried to rule it out. And I've seen tumors and other restrictions and even foreign bodies that are within the upper airway. If it's just a cough, quite often the heart can mechanically, and I know that there are some people that don't agree with it, but I certainly see in a lot of coughing dogs that the trachea is deviated towards the spine. And I believe that because of the mass effect of an enlarged left atrium and an enlarged heart, pushing the trachea dorsally, it's going to compress it against something and create some irritation. But with heart disease, too, we can get into left heart failure signs and increased pulmonary pressure that is associated with left heart failure. And so we're going to see in dogs perihilar edema, an alveolar lung disease. And in cats, it seems to be more of a peripheral type of lung disease than for heart disease, for heart failure. But there are other conditions that we're going to be looking for, and especially look at the cranial lung lobes. And that's best seen on the VD view, but it's hard to get the VD view positioned correctly so that the sternum is superimposed over the spine. And then the heart is going to be in the center of the radiograph. If there is a problem in seeing through the scapula, which there quite often is if you're pulling the dog's legs forward or cranial, then you can place the humerus alongside the chest cavity and pull the scapula off of that cranial portion of the thorax, and you're able to see the cranial lung lobes much better that way. So that would be a fourth VD view, that if you have a trough or some kind of positioning device where you can keep the animal positioned in a nice straight position, just pull the legs back. Usually takes an extra technician to pull the legs over to the side, or tying some kind of tape or gauze around and pulling those legs caudally away from the chest cavity. Then I think not having a preconceived idea of what the diagnosis is probably one of the reasons us radiologists that do consultation are still around, because we look at the whole radiograph, as every veterinary student was taught. And not only just looking at the lung parenchyma, but looking at the pleural space for fluid or fissure lines, looking at the location of those lungs and trying to ascertain whether the disease is in the lungs themselves or is outside of the lungs. Even looking at the position of the diaphragm can be helpful, because when the diaphragm is retracted caudally, then it allows expansion of those lungs, and so you're able to see more of the lung parenchyma that way, as opposed to a diaphragm that is in contact with the heart for an extended period of time. Those lungs are collapsed down, and you don't get nice filling of the lungs with air.
Well, I hate to keep drawing back to horizontal beaming, but I'm thinking with pleural fusion, it's really nice, or it's been my experience on the human side, that you get the fluid level, where when you're doing a lateral recumbency.
If you're looking for a fluid level, you want primarily a hollow viscous structure, and in the thorax, you're probably not going to see the fluid level on a horizontal beam, but you bring up a great reason for horizontal beam radiography of the thorax and a VD view, and that is for pneumothorax. Because if there's air in that chest cavity, it always goes away from the table. And on a VD view, it's going to come up around the heart and around the sternum. And on a DV view, you may see a retraction or the air out towards the costophrenic angles. So that would be helpful. But horizontal beam radiography is an excellent way to not only look for lung bully, as well as for pneumothorax. And that would be where I would see the biggest indication. And I've done that many times in academia, as well as in specialty practices, looking for cases of pneumothorax.
But for pleural effusion, you wouldn't really see.
I think that seeing fissure lines between lung lobes is probably the best to look for pleural effusion.
And auscultating.
Auscultation, quite often when you're auscultating, you're going to have muffled heart sounds. They're not going to be as nice and prominent. But I'm not the best at auscultation, so I could probably miss that very easily. But listening for the lung sounds in each lung lobe is going to give you a clue, and that'll be good. And then the other thing with regular radiography is that you're going to look for each individual lung. There's 4 lung lobes on the right and 2 on the left, although quite often the compartmentalization of the left cranial lung lobe, even though it has one common bronchus, that bronchus bifurcates very soon after. And so there are really 2 compartments of the left cranial lung lobe. But there's 6 lung lobes in the dog and in the cat as well. And so you want to make sure that you look at each area and get a pattern. I probably on the VD view start with the right lung lobe. I don't know why. And then I go to the right middle lung lobe. That's the one that it's most commonly affected with lobar alveolar lung disease or pneumonia, because it's low, and so anything that's aspirated will go down into that. Also, it can be collapsed easier. And third of all, that if there is lung lobe torsion, such as in cats, it's going to be bigger, and you'll be able to see it over around the 4th through 6th rib spaces on the right side. And then the caudal lung lobes, I usually look at the right, and then at the accessory lung lobe, and then on the left, and then go back up. And you could go either way, but I'll go back up and look at the left cranial lung lobe probably last. Now, my cursory look at the lateral view will tell me where I think the lung disease is, but if it's a right lung lobe disease, you may not see it that well with a right lateral recumbent view. So that's where I think the left lateral recumbent view is very helpful, because then you're going to see that more highlighted because of the air going up away from the table.
If someone's doing a METS check, is that again something that does require all 3 views or even more if they're going to be sending out to a radiologist?
Well, I think the new standard, and that's probably 20 years old, so I'm giving my age away here, but in the recommendation is to do both lateral recumbent views, because again, using the air in the up lung, the away from the table lung, it allows you to see smaller nodules, and your eye will pick those up easier. Also with the DR systems or the CR systems, the digital radiography systems, you're going to be able to see smaller lesions. We used to say with film that 3 to 4 millimeters was the smallest that you could ever see. But I think now with DR and the resolution, it may be hard to differentiate a 2 millimeter lesion from a pulmonary vessel end on, but you want to see if you can trace that nodule back to a pulmonary vessel. If you can't, then you need to start looking at other places or possibly take additional radiographs at different exposure techniques.
I was just going to ask about that. If varying the techniques,
are they
helpful?
Stage of respiration, the technique changes, and the algorithms. Some systems have 3 or 4 algorithms, and you can switch back and forth between algorithms to highlight those areas that you want to see, whether it's air density or whether it's soft tissue density. All of that can be very, very helpful.
If you wanted to experiment and try different techniques, would you suggest more KVP or more mass?
Well, they say to use more KVP for the lung. And I think that's true because then you can keep your time shorter. But with the new generators, the 3-phase generators, that probably isn't that much of a problem. But I think that using varying techniques, radiographic techniques with your X-ray machine can help to accentuate some of those things.
So playing around with KVP.
Yeah, but most practitioners are not going to have the time, and most technicians don't have the eye to even determine whether a radiograph is good quality or not. One of the things that it just came to my mind was that with deep-chested dogs, quite often the positioning on lateral views is inferior because they forget that the sternum goes down towards the table so they get an oblique view. And if there is some way you can either put a wedge or just take the down legs on the patient, the recumbent legs, and rotate that chest up so that you have a line parallel with the table between an imaginary line of the sternum and the spine, then you're going to get much better lateral views. And collimating down. You center the beam not over the mid portion of the thorax looking from ventral to dorsal. You center it closer to the sternum because that's where the heart and lungs are. The dorsal 1/3 of the chest is of the spine, the rib cage, and the fat. And so you will really want to center the beam 2/3 from the dorsal side and 1/3 from the sternal side, so you're centering right over the heart, and then collecting the information about the lungs around that area, including the diaphragm for sure, but you can collimate down so that you don't get a problem with scatter radiation.
And if you have some of those big breeds, it's okay to take 5 views, right? Just so
yes, I guess that's true. I think it's important to be able, on lateral views, to be able to see in front of the heart if you're looking, even centering back further. But if you've got a 125-pound Rottweiler or whatever, it's going to be hard to get on a 14x17 or even a 17x17 cassette. And on the VD view, that's probably even more, that you're going to need to take one that's centered closer to the xiphoid and another one that's centered closer to the manubrium sterni, rather than being successful as you would with most animals under 90 pounds, that you can get all of the thorax on those views.
Well, great. Thank you. Is there any other tip that comes to mind on imaging thorax or abdomen, since we started this session talking about abdomens, when considering the radiographs and the positioning that we were just talking about, using a wedge in the thorax and getting the sternum and the spine parallel to the table? Are there any other nice little useful techniques or hints in positioning that help you as a radiologist see more or be more confident in what you're seeing?
Well, I think my background in anatomy has helped me to understand that I would really like to see the anatomy completely. And so if the technician has this mindset, which some of them do that do very good radiography, or the veterinarian, that they can actually visualize what that should look like before they make the exposure. and try to get that exposure for the thorax during inspiration as often as they can, and of the abdomen on expiration, because then you change the motion pattern there. And finally, I think with the new DR systems, we have this tendency on cats and small dogs to do a whole bodygram. And I think we're doing a little bit of a disservice. If we're charging per view, I can understand it, but I think we're doing a little disservice to the clients if we use the same technique for thorax and abdomen, because most of the digital systems now are set up so that you place the anatomical icon, whether you're taking a thorax or an abdomen, and then it automatically will set the exposure for that area. And if you're setting up your X-ray machine, you need to be thinking that this is an abdomen versus a thorax and not try to mix and match just because you got an X-ray beam coming out. You want that beam to be appropriate, both KVP and MAS, for the anatomical area that you're at.
That's a good point, because I do see a lot of catograms and dogograms out there.
You can get by with it better on the cat, but the dog, I think it's more critical, probably because they have more of a barrel chest, and that you're wanting to really look at different things in the lung than you are in the abdomen. In the abdomen, you're looking at serosal margins, the outside of the organs. Rarely are you going to be able to see anything that doesn't have one of the 5 contrasts, which would be air, fat, soft tissue density, mineral or metallic. And so in the lung, you're seeing differentiation between different soft tissue and air densities, and you're not really worried about the bone or the fat as much. But a big fat dog, the thorax on that dog is going to look a lot different, and you may have to change your technique, especially increasing the KVP in order to compensate for that 1 centimeter of fat pad around the whole dog in the subcutaneous tissue.
Great. Well, thank you very much for your time. I know
My
your
pleasure.
time is valuable, and we appreciate you sitting down with us and discussing some of these little helpful hints and tidbits to have better radiography and better diagnostics.